Hi, and welcome again to our pediatric endocrinology talk about growth. I'm Dr. Sonia Lugo-Ruiz, and today we will be discussing the pediatric red flags for growth. I will be also addressing common conditions related to growth. If you wish to learn about calculation of the midparental height and growth velocity, please refer to my previous lecture. Let's begin. In the first few years of life, there are variations in growth. Think that as patients start to walk, they will often resist and be difficult to be measured in supine positions. They will also start trying table foods, having some preferences towards certain meals. Keep in mind, especially for board questions, that 50% of parents will tell you that their child is a picky eater. Unless you see a growth chart in that question and in real life that is actively showing that there are issues with weight gain, this should not be considered a red flag, as there are variations in parents' perceptions of being a picky eater. How do we approach growth problems? So, in general, we need to first start focusing on the exogenous factors like diet, sleep, and activity pattern, as certain patients might be sometimes too active for the amount of food that they eat. We can also obtain the midparental height and also understand how the parents had their pubertal development. This can help us understand if we have parents that are late bloomers or might have some constitutional growth delay. At the end, we also plot in the growth chart and we observe the trends between height and weight. Keep in mind, especially for questions, that the first thing affected in endocrine conditions is height. In here you can see two different growth charts. The one to your left is showing a patient with Cushing's syndrome. You can see that as the patient turns from 7 to 8 years of age, you see an increase in the weight gain, but you also see a growth deceleration. You can tell that as the patient reaches ages 9, 10, and 11, the patient is actually continuing that weight gain, but at the same time is decreasing in the height gain. To your right, you can actually see a growth hormone deficiency patient. You will see that the weight continues to trend along the 75th percentile, but the height starts to decelerate between 10 and 11 years of age, and you can see that it just flattens out. These are typical endocrine conditions. For general considerations in growth problems, we need to consider the following labs and imaging. This is able to help us to understand that there are certain nutritional factors as well as genetic factors that might have an impact in growth. We consider simple labs like a CMP and a CBC. We also address the adrenal glands by doing ACTH and cortisol. And we talk about thyroid function testing, especially measuring TSH and free T4. Growth factors like insulin growth factor 1 and insulin growth factor BP3, or binding protein 3, are very important to address if we have any type of suspicion for growth hormone deficiency. Keep in mind that we don't do the labs for growth hormone alone, because this is a pulsatile hormone that might not be an accurate measurement. We do instead IGF-1 and IGF-BP3. If we have a suspicion for delayed puberty or precocious puberty, we can always address LH or luteinizing hormone, FSH or follicle stimulating hormone, testosterone in males, and estrogen or estradiol in females. Any female that has a short stature or is not able to meet the midparental height should get a karyotype, as we have a lot of patients that go often undiagnosed but have Turner syndrome. The SHOX gene, or the short homeobox gene, is actually located on the X chromosome and has been found to be linked with isolated short stature or idiopathic short stature. Finally, if we have a suspicion for celiac disease, we measure the antibodies for tissue transglutamatase. Imaging should start with a bone age x-ray, and before we move forward with thinking about growth hormone therapy and growth hormone stimulation testing, we should do a brain MRI with pituitary cuts. This is taking into consideration that a notable amount of patients that suffer from short stature, growth deceleration, and delayed puberty can show with tumors or malignancies, such as craniopharyngioma. A bone age x-ray is no more than a picture of the left hand. In here, you can see that there are different growth plates, and you can understand and correlate with the Radiographic Atlas book. The normal range can be between or within 2 standard deviations. A good report should include both bone age, chronological age, preferably in months. Karyotype, again, should be considered for females with short stature, a child with delayed puberty, and anybody that has dysmorphic features. Dysmorphic features can be considered as low-set ears, hypertelorism, or any other facial features that might provide some sort of suspicion. To your right, you can see an example of a karyotype. On top, you can see an XY karyotype, and at the bottom, you can see that there is a missing X, showing that this patient has Turner syndrome. We have multiple differential diagnoses for growth problems. In here, I will only address the most common 3 ones. Constitutional growth delay is going to show a history that presents parents' height as being in the normal or even tall range. There will also be a parent history of being late bloomers. Fathers will often tell you that they didn't have to shave until they were very into their high school years. A patient is probably going to look very young. When you calculate the growth velocity, you will see that it's adequate for age. And when you look at the growth chart, you will see that the patient had probably a good birth weight and started to develop very well, but then turned out to be slightly below the curve. Again, when you calculate the growth velocity, it will be adequate. So I usually tell people it's kind of like the ugly duckling story, in which they might not look like their peers, but eventually they will catch up. Labs are going to be normal, as also the bone age will be normal. It will probably also present a delayed bone age compared to the chronological age, but usually within those standard deviations that we mentioned previously. The treatment is watchful waiting. If you can see in here, constitutional growth delay, parents will often tell you that they buy new clothes for the child, but still the child looks smaller than his peers. The parents will also tell you their story about being late bloomers, and monitoring will be considering any treatment if by any chance we do see any delayed puberty. Most of the time, these patients will eventually catch up. You can see on both growth charts that weight and height continue to increase even though it's on the lower end. And at the end, throughout those teenage years, the patient is able to meet the target height or the midparental height. Familial short stature includes a history of at least one parent being short. Parents' history and development is within average range, and growth velocity is also adequate for age. The growth chart is also going to follow the midparental height, but the midparental height is going to be lower than what we expect. Bone age x-ray is going to show the same age or close to it, meaning that the bone age will be equal to the chronological age. And you can consider the prediction of the height at 7 years of age. Labs are also going to be normal, and the treatment is to monitor. Please keep in mind that these patients, although they might receive growth hormone therapy, will not achieve a higher expectation of their target height, meaning that you can't go over the genetic potential of each individual. These patients are not candidates for growth hormone therapy. So when you have short stature, you have to check for conditions like nutrition problems, heart disease, asthma and the use of any steroids, celiac disease and inflammatory bowel disease, kidney disease, anemia and bone disorders, any type of tumor history, genetic conditions, history for small for gestational age, and any medications that might interfere with height. Hormone deficiencies related to short stature will be hypothyroidism, growth hormone deficiency, cases of early diabetes, and Cushing's disease. And you can see that the labs that I previously mentioned are addressing these hormone deficiencies. And so, in summary, the most important test is to use that growth chart to your advantage. And the main image needed is that bone age x ray. Again, I want to say thank you for joining me today, and we will be talking about different topics in pediatric endocrinology very shortly. Thank you.